I'd like to introduce you to our guests for today's panel on early detection. Joining us are Dr. Leanne Woods-Burnham, an assistant professor in the Department of Physiology at Morehouse School of Medicine in Atlanta, Georgia, Dr. Brian McNeil, the Associate Dean for Clinical Affairs and Vice Chair of the Department of Urology at SUNY Downstate Health Sciences University, and Dr. Kelvin Moses, an Associate Professor of Urologic Surgery at Vanderbilt University Medical Center and Director of the Comprehensive Prostate Cancer Clinic. Welcome to all of you. Let's begin by having the three of you introduce yourselves, starting with Dr. Woods-Burnham.
Hi, thanks for having me. I'm on this panel discussion, and I'm really grateful to be able to share this discussion with the other members of this panel today. I am an assistant professor at Morehouse School of Medicine in Atlanta, Georgia. I'm a basic scientist, and so my lab focuses on genetic and molecular reasons why Black men are more likely to have aggressive tumors when they are diagnosed with prostate cancer. But I also co-direct our community-based prostate cancer screening program, where we really try to ensure that men in Atlanta and also throughout parts of rural Georgia have access to screening at an age that is appropriate for them. I got into this field originally because my dad, he is a Black man. He was diagnosed with aggressive prostate cancer when he was 50 years old. And that was before he was screened, and he sort of found out on accident. And so I see in real time, even with him now, that this is something that had it been detected earlier, his options would have been different. He wouldn't be dealing with the stage of disease that he deals with now currently. And so that's really sort of my driving motivating factor for how I got into this in the first place. And I'm excited to work with this organization, ZERO, to try to tackle this head on over the next few months and years.
Thank you, Dr. Woods-Burnham. And Dr. Moses, can you please introduce yourself?
Sure, yeah. Kelvin Moses. I'm Associate Professor of Urology at Vanderbilt University Medical Center in Nashville, Tennessee. I serve as Director of the Comprehensive Prostate Cancer Clinic, which focuses on treatment for men with advanced prostate cancer. Additionally, I serve as the chair of the NCCN Guidelines Panel for Early Detection of Prostate Cancer. So this is something I have a lot of passion for. Additionally, I serve on the executive board and the medical advisory board for ZERO. So that's my connection with the ZERO team. I've been working with them for several years. My personal connection, I guess, as a Black man and someone in urology, I see the effect of people who are not screened. I see the effect of people who don't know about it. And I see the effect of how physicians in our field may not be cognizant or sensitive to the issues that Black men do face with prostate cancer. And so that's why I'm happy to participate, and thank you for the invitation to join this esteemed panel.
Thank you, Dr. Moses. And finally, Dr. McNeil.
Great to be with you, Jerry. Also great to be with you, Dr. Burnham and Dr. Moses. I like to say that we're all branches from the same tree, and that tree is the Morehouse tree. Dr. Burnham, as she mentioned, she's a professor at the Morehouse School of Medicine, and Dr. Moses and I actually attended Morehouse College together. I'm currently a urologist at SUNY Downstate Health Sciences University in Brooklyn, New York. I serve as the Associate Dean for Clinical Affairs, as well as the Vice Chair for the Department of Urology. And my personal connection to prostate cancer is this. I actually lost my father to prostate cancer just near the beginning of my senior year of high school. So early detection is a issue that is near and dear to my heart.
Thank you, Dr. McNeil, for that. So clearly this is not only do you have expertise, but you all, have personal connections, and you see this day to day in your work too. So I'm really thankful that you all can be here today to discuss this. So what the first question let's get started with is, we know that the Prostate Cancer Foundation recently came out with guidelines clarifying screening guidelines for and recommendations for Black men. Now, why were those guidelines necessary? Can we get into have a discussion about what, if there has been confusion in the community around screening, and why were these necessary in particular for Black men and the Black community? Dr. Moses, I'll start with you.
Sure. So confusion is the right word. PSA has been a controversial or confusing topic ever since it started being used for screening for prostate cancer. PSA actually was never originally meant for screening, and it is not a quote unquote good screening test. However, it has been used since probably the late 80s or early 90s on a regular basis. Part of the confusion lies in that there are many guidelines panels that make recommendations, including NCCN, on which I sit, and they all say something different. So there's no harmonization of the guidelines. And then the big wrench in the engine was the United States Preventive Services Task Force recommended against screening based on data that many of us in the field felt was premature and maybe misinterpreted. And so there's been a dichotomy in how PSA has been approached from people who treat prostate cancer versus those who perform screening on the front lines in the primary care world. Additionally, we've known over decades that Black men have had higher death rates from prostate cancer and that screening rates have not met the general population. And so there's the thought that there are biological differences, and that's the focus of Dr. Woods-Burnham work. And so that's why PCF came out with specific guidelines on Black men. Again, the only randomized trial that was done appropriately was done in Northern Scandinavian men, essentially. And so the applicability on men in the US, and particularly in Black men at higher risk, doesn't seem to match. And so Dr. Isla Garraway, who's a MD, PhD urologist at UCLA, helped convene this panel with PCF and make these specific recommendations for Black men.
Thank you for that. Dr. McNeil or Dr. Woods-Burnham, do you have anything to add to that?
He covered everything.
Okay, great. Thanks, Dr. Moses.
Yeah.
Well, the next question, let's talk about those guidelines, and since we've alluded to it, can Dr. McNeil, could you maybe bring some clarity to, because that's really what we want to do. We want to move from confusion that Dr. Moses alluded to clarity today, to hopefully clear some of this up. So Dr. McNeil, can you talk to the guidelines, and feel free, Dr. Moses and Dr. Woods-Burnham, to chime in as well, bring some clarity on what these guidelines say.
Not a problem, Jeremy. Before going into the guideline discussion, I'd like to put out there to everyone, I am your guideline. And I say that because I'm a Black male with a strong family history of prostate cancer. I'll share a little bit about the guidelines, and I'll tell you kind of how I have sort of behaved in my own life. As Dr. Moses mentioned, the U.S. Preventative Service Task Force recommended against PSA screening for prostate cancer. This was back in 2012 or so. There was confusion prior to that, and it got even worse afterwards. There were some tweaks made, and folks thought that you should have a discussion with your provider about prostate cancer screening if you're between the ages of 55 and 70. Most folks thought that, if you had a family history of prostate cancer, maybe you should start those discussions earlier, perhaps at around age 50. However, my personal feeling and that of the Prostate Cancer Foundation now is that prostate cancer screening should indeed start much earlier if you're a Black male, especially a Black male who has a strong family history of prostate cancer. Admittedly, I got my first PSA test at the age of 40, and I have performed it periodically since then. So if you're a Black male with a strong family history of prostate cancer, I think that you should have a discussion with your doctor at the age of 40 about whether or not prostate cancer screening is right for you. And you should certainly have that discussion before you turn 45. And I think that that's a good segue to Dr. Woods-Burnham to kind of lead us through the discussion of nature versus nurture. Why is prostate cancer screening different in Black men?
Yeah, sure. So there's so many different reasons, right? And if we knew if there was one and we knew, that would be amazing. But because it is multifactorial, that is what makes it a lot more difficult. And so what you're talking about in terms of screening at age 40 to 45, I would like to point out, Prostate Cancer Foundation and American Cancer Society have been alluding to this for a few years, regardless of what the task force was saying. And even with the task force recommendation changes, there was a small paragraph, if you scroll all the way down to the bottom, that said, we have patient populations under consideration. But I don't know how many clinicians were following that. I published a study out of Southern California when I lived there, where we reported that 55% of Black men, their physicians never even talked to them about the pros and cons of screening, even though they were in that age bracket. And so we're hearing, from the experts on the panel here that are in the clinic, they are urologists offering this, but not everybody is as up to date as they are on this topic. And I'll speak from personal experience. So my husband, when he was 40, he's a Black man. He has multiple family members who were diagnosed with metastatic prostate cancer. That's when they found out. So I want him to be tested at age 40. And then, this is what I do for a living. So I was counting down to this birthday. I couldn't wait for him to get his PSA tested, right? And I brought him to the doctor, and when I say the doctor refused to run the PSA test, that's an understatement. This was a whole back and forth for 10 minutes that escalated, and the doctor ended up walking out and slamming the door and just telling the nurse, just go ahead and order it, just so they can just leave the office at the end of the day. His PSA levels were normal, thank God, but I just thought it should not take all of this, to get a PSA test. And so what Prostate Cancer Foundation has done with these new guideline recommendations is just add an extra reinforced statement. If you look at the co-authors on that recommendation, these are heavy hitters. We'd be hard pressed to look at this recommendation and just throw it away and not consider it seriously. And so I'm really hoping that will help inform some screening guidelines at institutional levels. I've seen that here in Atlanta happen in real time. And so we have a major health center called Grady Health right on the 20 in downtown Atlanta. In 2022, when I arrived to Atlanta, they were not screening regularly PSA testing for men that came in the door necessarily. And so we had discussions. There was a lot of meetings surrounding that. And in the fall of 2023, a lot of this based on what Prostate Cancer Foundation was working on. Now, if you are over age 40 and a Black man walking into Grady, you're getting a PSA test. So these are certain things that have a major impact in Atlanta, specifically where I'm at. But if we can sort of have that happen in different pockets throughout the U.S., that will make a big difference over years to come.
Mm-hmm.
And so it sounds like the guidelines. Thank you for that, Dr. Woods-Burnham. I appreciate the personal story too. I know how frustrating that must have been, and I know that your husband is not the only one that experiences that level of pushback. Mm-hmm. Unfortunately. Dr. Moses, just to clarify so everyone understands, sounds like starting at age 40, is that correct? That the recommendation is that Black men should start discussing with their doctor the recommendation, or that they should start discussing with their doctor whether or not they should consider beginning screening, PSA screening at that time. Is that correct?
Yeah, I use 40. The NCCN says 45 for Black men, and we've had discussions / arguments about should we scale that down even further. But I tell men 40, and when I go to different, community events, I use 40. The median age that Black men are diagnosed is younger. If you look at data that Dr. Woods-Burnham alluded to from Yanyami in Seattle and others, Dr. Isaac Powell in Detroit, they did autopsy studies and found insignificant prostate cancer in men as young as their late 20s or early 30s, but the progression of disease was faster even from starting out the same compared to white men. And so, yeah, I definitely, I got mine. I got a baseline at 35 actually, and then do it annually since 40. And my story is similar to Dr. Woods-Burnham's husband. I was a urology resident, and the PCP argued with me, and I was like, do you understand what I do for a living? Like, why we're having a shared decision-making moment here, and I, as the patient, have decided what I want. But it was like an arm wrestling match. So, imagine someone who may not have the information that we come in the room with, trying to have a discussion with someone who's pushing back. So, having that discussion at 40, and part of it for 42 is that, or 40 also, is that Black men need to go to the doctor, and you need to just get your blood pressure checked, and your glucose, and your cholesterol, and your colon, and all of that. So making that part of the discussion, and having a healthy prospective outlook on your health is important. Again, early detection means, or early screening, early detection means you have all the options, and you can maintain quality of life, and live out your years normally.
Thank you, Dr. Moses. Dr. Woods-Burnham, I'm going to come back to you. And you've all alluded to this, but it's interesting, you were talking about the pushback. Dr. Moses, you talked about that. So what does someone do if how do we transition this conversation into the community, and empower people who are like, I don't have a PhD or MD. How am I supposed to push back if I do face a barrier where someone is not wanting to give me this screening at the age of 40, or 42, or whenever they begin this, and they're telling them to wait? How can we empower patients to feel comfortable in asking the right questions and presenting this conversation to the providers? And I also want to even step back and say, ask the question, where do people go if they don't even have a regular provider? How can they kind of get connected and receive care?
Well, what we tell people is, if someone's clinician does not know the proper guidelines for a Black man in his 40s who might have family history, then I'm just going to assume he's not aware of what's up to date for colorectal cancer, for breast cancer. I'm just going to assume he's just not updated in terms of that, he or she. So I'm a strong advocate for moving on to the next person. That's what I did in that situation with my husband. That was our last visit with that person, and we just found somebody different that we were comfortable with. So that's what I would recommend. But when we are out in the community, it's kind of alarming, the number of men we run into who don't realize that they are at higher risk. So that's the first thing, is to even understand and know that that is the case. But other times we also run into where men either are uninsured or they're underinsured. And so at Morehouse School of Medicine, when we're out in the community providing education or free PSA testing, is we provide follow-up options that are multiple places in the state of Georgia where men can go that will cater to their insurance status. And we also provide specific provider names that we would recommend that they could go to for follow-up in the event that they have high PSA levels. So that's something that we've done here. And I did that previously in California with Dr. Rick Kittles, he actually is a co-author on that Prostate Cancer Foundation recommendation. And that was a model that we used, where you have to be careful when you're in the community. You don't want to make it seem that you're just trying to create this pipeline right into your own healthcare system. That is an important aspect. We want to be able to provide that care, but we also offer different options, because everybody's needs are different depending on where they live and what their insurance status is.
Thank you. And that's helpful to talk about too, is what are can we talk about, and Dr. Woods-Burnham, I think I'm going to go back to you. I will get to you, the rest of you, sorry, but can you talk about federally qualified health centers and their role in providing care for maybe people who find themselves uninsured or underinsured?
Yeah, so we have partnered in the past with some of these FQHCs, and they play a very important role, not just here in Georgia, but nationwide. And so, and sometimes people don't realize there are there is support at those FQHCs that are available to people who want to start these community-based health screening programs. And so we've partnered with some as well. So I would say for anybody interested maybe in starting something like that, or working with a center like that, just to inquire and see if there are opportunities like that exist.
So we've had some high-profile cases of diagnoses and deaths from prostate cancer lately, such as Secretary Lloyd Austin and Francis Collins being diagnosed with prostate cancer and sometimes aggressive forms. And then also Dr. King's son, Dexter Scott King, and O.J. Simpson dying from prostate cancer. So how has that, those newsworthy pieces of information, how is that affecting what you're seeing in the clinic and also what you're hearing in the community? Is that driving people to get screened or talk more about prostate cancer?
It is indeed driving people to have discussions about prostate cancer and prostate cancer screening. I think some make the assumption that if you're a person of notoriety or if you have access to resources, you're getting care and you're getting treated early for things. But in the case of Dexter Scott King, dying from prostate cancer at the age of 62 is quite alarming, because if caught early, this disease can be managed.
Thank you, Dr. McNeil. And Dr. Moses, how do we, we've already talked about this a lot, I feel like, but how do we work with the primary care community to increase these conversations, awareness, knowledge of the guidelines, particularly for Black men and men who are higher risk for prostate cancer, so that we don't get that pushback that we've heard about?
Yeah. One of the things we need to do as urologists and scientists is stop preaching to the choir. And so it's very easy to go in rooms and talk about what we know. But there are times where I go into maybe a somewhat hostile room and I've spoken to departments of medicine and family practice organizations and brought data. So when I speak to the community, I speak in one way. When I speak to physicians, it's in another way. And they want data. I mean, they want to hear why we believe what we do. And so I bring in the updated randomized trial data. I bring in the data from SEER, the statistics on Black men. I'll bring in data that shows reduction of death over time during the PSA screening era. And now what we're seeing is an increase in metastatic disease and death, which is just starting now, which makes sense. If people stopped getting screening, 10 to 15 years ago, we would just now be seeing these metastases and death. And so that's a lot of it. Advocacy groups have gone to the USPSTF and at least had them adjusted to a C grade, and maybe it can bump up to a B grade at some point with revision or reanalysis of data. I have sympathy for our primary care colleagues. I mean, they have a lot to deal with. They have to ask about blood pressure and sugar and diet and exercise and guns in the house and, everything else in 15 minutes. And so anything that can help simplify their visit is helpful for them too. So that's why I said at the outset, we probably need to have harmonization of our guidelines. We just had a great presentation at our American Urological Association meeting with Adam Murphy, really advocating for harmonization of the guidelines so it reduces the confusion and ambiguity in performing these tests for men.
In your work, are you experiencing, are there myths or misconceptions about prostate cancer or prostate cancer screening that are serving as barriers for some men in the Black community to get screening? Dr. Woods-Burnham, could we start with you?
Yeah, well, I would think the major one is men believing that they need to have a digital rectal exam first. And we let them know, that's a possibility depending on who your physician is. But it basically usually will start with the blood test, the PSA test. And so that's the first myth that I would say. The second thing that we run into is the thought process of if I eat right, if I exercise, if I do everything right on my end, this is not going to happen to me. I use my dad as an example. So when he was diagnosed with, his PSA was 64 when he found out on accident in the emergency room. He was a pescatarian. He only ate organic food. He worked out every day. You can do everything right, but there is something called genetics that will kick in. And what we know is that men of West African genetic ancestry, that there are variants that are associated with aggressive prostate cancer. And so I'm all for a healthy lifestyle. Please do that for so many multiple reasons, but don't do that and then think that you don't still need to have appropriate screening at an appropriate age. So that would be something else that we discuss often.
Thank you for that. Dr. McNeil, anything to add?
I think Dr. Woods-Burnham touched upon the big one, meaning the need for the digital rectal examination. I think another misconception is that every man who has a PSA level checked needs to get a biopsy. And that's not necessarily true. There are a number of men who fear having a biopsy done. And PSA, the blood test, it's a mere sort of tool that we use. And depending on what the PSA level is, we may watch it. There are some men who get a biopsy straight away, but there are others where we do MRI scans, because having an elevated PSA level does not mean that you automatically have prostate cancer. There are a number of things that can cause an elevated PSA level. And I think that testing sort of stirs a bit of anxiety amongst men and their families.
So there's some fear, it sounds like, either of having a digital rectal exam or, what may come next, a biopsy or something too, it sounds like. Is that correct?
Yes.
Yeah, okay. Thank you. I think I'm going to come to each of you with this question. So apologies if you come last, because it's going to be the same question, but what is, in your mind, what is the one thing that you would change or thinks needs to be changed to help reduce the barriers that men face to getting prostate cancer and finding it earlier? What can we do to really finally achieve health equity in terms of early detection and screening for Black men? Dr. Moses, I'll come to you first.
The biggest change is education, and not necessarily just patients. We go out in the community and we preach to them, but as I mentioned before, we need to sort of bring in all of our partners. There's some data I published with Willie Underwood. Black men less likely to get screened, less likely to get treatment, and less likely to get treated even with escalating disease. So with higher risk disease are actually lower risk, lower odds of getting treated. And so we need to reverse those trends. So we need to educate our medical cohort. Dr. Woods-Burnham has done a lot of work in diversifying clinical trials, and that comes with educating our industry and cooperative group trial designers to make sure that they're including the appropriate patients, and really diversifying our cohort in the physician, scientists, and allied health arena. So with education diversification, I think we can reverse a lot of the trends that we see.
Thank you, Dr. Moses. Dr. McNeil?
I think that we need to sort of reshape how we approach health, not to break things down under gender lines, but I think that from, say, one's teenage years, I believe that women develop relationships with their primary care providers. Sort of seeing a gynecologist, having a pap smear is something that everyone expects to do for the most part, and women tend to do throughout the majority of their lives. Men, oftentimes, we avoid conversations surrounding our health and we establish relationships with healthcare providers much later in life. I think that comes back to hurt us in some ways. The thing that I would change is I wish that men, myself included, would feel more vulnerable and comfortable having conversations about health and the things that impact us as we age.
Dr. Woods-Burnham.
Again, I'll use my husband as an example. I think that we need to make things as easy as possible when the patient is walking into an appointment. My husband is the type where he says, what day is this? Where am I supposed to be at? I'll just go, and then can you go online in the My Chart and just read the results for me afterwards? He's not going to go in and say, now, what are you testing in my blood? And so if the man goes to the clinic and he's going to have things run, it would be great if the PSA test is just something that's standardized, available along with the other tests, and something that the patient does not have to advocate for themselves for. And, I think that's what is also important with ZERO really advocating for the PSA for Him Act to allow to have no cost barriers for men in their 40s or high risk populations to receive the PSA testing when they go to the clinic. So I just think really reducing as many barriers, making it something simple that's already available to be tested would be the easiest way to affect change.
Thank you for mentioning that. Policy change is important too. So yeah, thank you for mentioning that, because we hope to see that happen soon. I just want to ask, is there anything that we haven't covered that you think is important in this conversation that you want to convey today to the audience?
I'd reiterate something Dr. McNeil kind of mentioned early. Not everybody that has a PSA has prostate cancer. Not everybody that has prostate cancer has to be treated. Not everybody that has to be treated is going to get debilitating side effects. So, men and everybody, you start talking about cancer or the risk of cancer, and your mind automatically goes to some movie or TV show with some hairless person who's gasping for air, and that's not necessarily the case. So, and that, again, that's where the education piece comes. That's where the shared decision making comes, and that's where the getting out in the community and letting people know, why we do this and how it can save lives. So, more information is always better, and more knowledge about the information you have is better. So, don't automatically go to the worst case scenario. And if you're getting screened and early detection, then you don't even have to worry about the worst case scenario, because you can deal with it at a much easier level.
Well, thank you all for this incredible discussion. It was a joy to talk with you about this important topic.